Hi everybody, and welcome to our module on blistering disorders. Let's start by talking about blisters. Blisters are the common name for fluid-filled skin lesions. They are caused by a separation of skin layers, and the space beneath the skin layers fills with fluid. This is a picture of a blister shown on the screen here. And in some blistering disorders, the blisters will rupture, so you won't actually see a blister like what's shown here. You'll see what's left behind after the fluid-filled space ruptures. And the technical term for blisters is a vesicle if the blister is less than 1 centimeter in size, and a bulla if the blister is greater than 1 centimeter in size. And there are many causes which we won't discuss in this video. If you've ever had a burn, that can cause a blister. If you have friction on your fingers or hands or arms, that can sometimes create a blister. In this video, we're going to focus on some skin disorders that lead typically to blister formation on the skin. Let's start by talking about pemphigus. So pemphig is the Greek word for blister. That's how this disorder gets its name, because it involves blisters. The pathologic hallmark of pemphigus, and it's very high yield for you to know this, is acantholysis. This is the loss of connections between keratinocytes, and that's what allows these blisters to form. We'll talk more about this in a minute. In addition to the skin, pemphigus also involves mucous membranes, especially in the mouth, and this is an easy way to recognize pemphis in a board question. And there are a number of subtypes of pemphigus, but the only one we're going to talk about in this video is pemphigus vulgaris. If you don't know this, the word vulgaris means common, and therefore pemphigus vulgaris is the most common form of the pemphigus disorders. Let's talk briefly about the pathologic process called acantholysis. This refers to a loss of connections between keratinocytes. Often it involves a loss or some damage to the desmosomes that link keratinocytes together. What you see histologically are rounded keratinocytes that are detached and freely floating within the epidermis. This is a picture of acantholysis on the screen here. You can see these rounded keratinocytes. They're freely floating, and they've created this space in the epidermis that can fill with fluid, and that's what can lead to blister formation. And it's very high yield to know that acantholysis is a hallmark feature of pemphigus vulgaris. The reason acantholysis develops in pemphigus vulgaris is because of autoantibodies against desmogliin. Desmogliin is a component of the desmosomes, and as I told you on the last slide, loss of desmosome connections is often what leads to acantholysis, and that's also what leads to pemphigus vulgaris. This is an example of a type 2 hypersensitivity reaction. This disrupts mostly the connections in the stratum spinosum. So if we look at this picture here, this section here above the basal layer is the stratum spinosum. And when connections are lost there, fluid can fill above the basal layer, and that can lead to blisters. This is mostly a disorder of adults. The typical age when it occurs is about 30 to 60 years old. And pemphigus vulgaris is one of several causes of Nikolsky's sign. Nikolsky's sign is when the skin will slip off with a gentle tug. You can see that in pemphigus. You can also see it in staph scalded skin syndrome in children. You can also see it in Stevens-Johnson syndrome. And in all of these syndromes, what's happening is that you have loss of connections in the epidermis, and that allows the skin to just slip off. That's called Nikolsky's sign. The clinical picture of pemphigus vulgaris involves large flaccid bulli that easily burst. And the word flaccid is important. These are not tense bulli, they are loose and floppy. Often few of them are intact because most have ruptured and scabbed. So what you more often see is a picture like what's on the right side of the screen here. You do not see a lot of bulli here. Instead, what you see are bulli that have ruptured, and now you've got the scabs and the effects of the rupturing. It often initially develops with oral bulli and ulcerations in the mouth. It's very high yield to know this. This is a picture of someone with pemphigus in the mouth, so they may complain of pain on chewing or swelling inside of the mouth, and then when you examine the mouth, you see these ruptured bulli here. The classic pathology finding in pemphigus vulgaris, other than acantholysis, is positive immunofluorescence for IgG antibodies in a reticular pattern. The word reticular means like a net, and this is what the immunofluorescence pattern looks like in pemphigus. It's shown on the screen here. So what's happening is IgG antibodies are attacking the keratinocytes. They are surrounding the keratinocytes. So when you do immunofluorescence staining for IgG antibodies, you see all the borders of the keratinocytes light up, and that makes this reticular pattern that looks like a net. This disorder is treated with immunosuppressants, and it carries an increased mortality. First of all, patients easily develop infections when their skin breaks down, and there are also potential complications that are side effects of the immunosuppressant therapy. Next, let's talk about bullous pemphigoid. So this disorder gets its name pemphigoid because it looks like pemphigus. And this disorder is also an autoimmune or hypersensitivity disorder, but in this case, the autoantibodies are directed against hemidesmosomes. I talk about hemidesmosomes in the video on epithelial cells, but these are the attachments between keratinocytes and the basement membrane, in contrast to desmosomes, which are attachments between one keratinocyte and another keratinocyte. The proteins in the hemidesmosomes that are involved in bullous pemphigoid are called bullous pemphigoid antigens. They are proteins, and they go by names like bb1 and bb2. And as I said, they attach epithelial cells to the basement membrane, just like all hemidesmosomes. The bullae in bullous pemphigoid are subepidermal, so they are not caused by disruption of desmosomes, they are caused by disruption of hemidesmosomes. Therefore, fluid fills beneath the epidermis in the space where the keratinocytes would normally attach to the basement membrane. In addition, the bullae are non-acantholytic, so acantholysis is not a hallmark feature of bullous pemphigoid. Because of these two features, the bullae tend to be less fragile and flaccid compared to pemphigus vulgaris. Usually they remain intact and they are tense. You see less rupture of bullae and scab formation compared to pemphigus vulgaris. The hallmarks on biopsy are, first of all, eosinophils and lymphocytes. I'll show you a picture of this in a minute. And if you do immunofluorescent staining, instead of seeing that reticular pattern, you see a line at the base of the epidermis, and that should make sense to you. This disorder involves the hemidesmosomes, which attach to the basement membrane. So basically, you're going to see a line of immunofluorescence that mimics the basement membrane. Shown on the left side of the screen is an example of some of the skin findings you can see in bullous pemphigoid. Note that there are unruptured blisters present. Notice also that the blisters are tense, meaning the fluid inside the blister is pushing up against the edges. On the right side of the screen is a biopsy from bullous pemphigoid. Note that there are eosinophils, which you can see within the blister space. This is largely a disorder of the elderly. The median age in one study was 80 years old, so it's going to be an elderly person in a board question. This rarely involves the mouth, which, as I told you before, is typical of pemphigus vulgaris. In addition, there is no Nikolsky sign in bullous pemphigoid. This is treated similarly to pemphigus vulgaris with immunosuppressants, and it also carries an increased mortality. However, the mortality increase is less compared with pemphigus, and that's because the bullae do not rupture as often, so there's less chance of infection compared with pemphigus vulgaris. The last disorder we'll talk about in this video is dermatitis herpetiformis. This is a skin condition that's associated with celiac disease, and I talk about celiac disease in greater detail in the GI section in the video on malabsorption. But people who have celiac disease can develop an associated skin condition, and that's called dermatitis herpetiformis. This disorder gets its name because the lesions on the skin look like herpes. That's why it's called herpetiformis. They look like what's shown on the screen here. These are papules and vesicles. They're usually in groups, and they're usually bilateral. That's what herpetiform means. And because vesicles develop, this can sometimes be referred to as a blistering disorder, although you do not see the large bullae we talked about in pemphigus and bullous pemphigoid earlier in this video. The rash of dermatitis herpetiformis is pruritic and itchy, and it's classically on the extensors. So in a board question, it will appear on the elbows and the knees in a patient who is known to have celiac disease. The cause of dermatitis herpetiformis is IgA deposition in the dermal papillae. So the dermis layer of the skin has these little finger-like projections. They are called papillae. IgA deposits at the tips of those papillae, and that's what leads to dermatitis herpetiformis. There are numerous small lesions that are found at the tips of the dermal papillae. As I said before, this occurs in individuals with celiac disease and genetic gluten sensitivity. What is believed to occur is that antibodies triggered by gluten cross-react at the skin, and that leads to the IgA deposition in the dermal papillae. On biopsy, what you see are microabscesses, which are really just spaces at the tips of the papillae. There's one shown in this picture here, indicated by the arrow, and in those microabscesses you can sometimes see neutrophils as well. On immunofluorescent staining, the hallmark is IgA deposition at the tips of the dermal papillae. So it looks like what's shown on the screen here. These bumps that are lighting up bright green are the dermal papillae, and this is immunofluorescence done for IgA, so that indicates there's IgA deposition in the pattern consistent with dermatitis herpetiformis. So we'll finish with this slide. As I told you before, there are lots of causes of blisters, but in this video we've been talking about antibody-associated blistering disorders. We talked about how pemphigus vulgaris is caused by IgG antibodies against desmosomes in the stratum spinosum of the epidermis. Bullous pemphigoid is also caused by IgG, but the target is the hemidesmosomes, which are located along the basement membrane. Remember, the hemidesmosomes attach keratinocytes to the basement membrane. And then finally, we talked about dermatitis herpetiformis. This is caused by IgA antibodies. This is gluten related. It's common in patients who have celiac sprue, and the antibodies in the case of dermatitis herpetiformis are found in the dermal papillae. And that concludes our video on blistering.